This is James from Central DeKalb. Glad that you've joined us. And of course, our big superstar, Keith and Raquel, are with us today. And we welcome them. And of course, they have all your Medicare information for 2022, including some from me, by the way. But hope you enjoyed this presentation. And don't forget, put your questions in the chat, and we'll see if Keith and Raquel will get them answered for you. Keith, it's all yours.
Thank you very much for that introduction. Hello, everybody. I'm glad to be here today. My name is Keith Nabb, and my agency is Affordable Medicare Solutions. And in the chat box, my assistant Raquel will be putting our company information in there with our YouTube channel and our website and phone numbers. I have myself and 10 employees. We're the largest Medicare planning agency in Georgia, and I've taught around 1,200 classes on Medicare to all different types of people. So about half of the classes we teach are to consumers, just like yourselves. And then about half are to professionals like nurses, social workers, financial planners, and attorneys. There's a big problem today. The government is not sending people out to teach about Medicare. So there needs to be 100 of me out there teaching, and there are a few other people around the United States to teach on Medicare, but it's a problem. I tell you, the last place you want to learn about Medicare is from Joe Namath or JJ Dynamite Jimmy Walker on TV. There's a lot of noise, and you're going to get a lot of noise here very quickly because tomorrow is October 1st, and the Medicare marketing season starts tomorrow. It's like hunting season. Be aware, there's people out there going to be hunting you down about Medicare. Be careful. My job is to show you how to be a better consumer, and that's what my agency does for thousands of seniors. And a lot of you, I see in the chat box, I see some names of people that I know that have probably sat through this presentation once or twice before, and I appreciate you coming back. Think of all of your friends that didn't come today, how lost in the woods they might be when it comes to this subject, or they might think they know certain things and they actually have misconceptions and misinterpretations of what's going on. So I'm gonna share the screen today, and we're gonna learn, spend about 45 minutes together, and hopefully I'm gonna help you save $100, if not $500 next year. And that's my goal, is for my seniors to save as much money as possible and to not be taken advantage of. Unfortunately, the system is stacked against you. So let's fight back together and learn something new today, okay? All right, I'm gonna share my screen. And this presentation, it says on this screen, The Beginner's Guide to Medicare. A lot of you are already in Medicare, and you might have retiree benefits. Remember, this is really important. If you have TRICARE, or if you have teacher's retirement or other retiree benefits, be very careful to not mess up those benefits. Or if you're required to use a certain Medicare enrollment system, like if you're an AT&T or an IBM retiree, they might say you've got to go through a certain process to take care of your Medicare. Well, I'm going to teach you how to be smart when you're dealing with those people. But if you're a normal Medicare beneficiary who is buying and analyzing and taking care of their own Medicare benefits, this presentation tells you how that we can help you, or you can do it yourself, to manage your Medicare using the Medicare website and free resources like my office. All of our services are free. So let's look at the first screen. It says right off the bat that I do not work for Medicare. This presentation is for educational purposes only. I do this as a public service. Of course, I have to be licensed and certified, and with all of the different products, it's a big pain in the neck, but I have to do that every year, and all of my employees have to do that also. Complete information is available at Medicare's website, medicare.gov. Never, ever, ever go to medicare.com. They will try to sell you stuff over and over and over again. Be careful. It's medicare.gov. We're not going to share any plan names or company names or prices today. And additional educational flyers are available. If you look in the chat box, you can see that at our website, there's a whole library of educational flyers. But even better, a blessing of COVID was that we started recording videos and putting them on our YouTube channel. So this video is going to be on the YouTube channel, as well as all sorts of other informational videos. Some are 5 minutes long, some are 2 minutes, some are 50 minutes. Just go to the videos. Here's the problem. 1965, the year before I was born, 1965, Medicare was born, and so is Medicaid. Medicaid is a program for the low income, whereas Medicare is for everybody. It's a federal program, of course. Medicare is not the same as employer-based insurance, veterans benefits, or Medicaid, but you can have Medicare alongside Medicaid or alongside your work plan at work, or you can have veterans benefits alongside your Medicare. You just cannot have the Affordable Care Act alongside your Medicare. You can have one or the other. They cancel each other out. You can't have them at the same time. Now, when Medicare was created back in the 60s, they said, we're going to create this for people who are turning 65. Well, the average length of life at that point was about 66 or 67 years old. So they were just thinking this was a temporary program. And it was also for the person who had a non-working spouse. So your non-working spouse would qualify under the working spouse's work history. But then some people raised their hand and said, well, wait a minute, wait, Bob got hurt at the factory. He can't work anymore. He can't walk. He's got a disability. So Social Security created an income program called Social Security Disability Income. And if you're on that safety net to help you keep food on the table and a roof over your head, after 2 years, they also automatically would assign Medicare to you. I don't know what the people did for those 2 years, but after 2 years, they got Medicare. Now we use the Affordable Care Act to help those people during that delay. But then there was another set of people that raised their hands and said, well, wait a minute. This person's got kidney failure. Not only are they disabled, but they've got failing kidneys and have to have kidney surgery or transplants. We need to give them health care immediately or they're going to die. They have to have dialysis. So they created this third type of eligibility where if somebody has Lou Gehrig's disease or end-stage renal disease, they get Medicare as early as 4 months into their disability. So the government has been expanding the eligibility. We're going to stay in the 60s. Back in the 1960s, the hospital was the place. Everything that was major got done at the hospital. And that's changed over the years. But when Medicare created this program, they put all of their eggs in that hospital basket and said, hey, the hospital coverage is free. We're going to make sure everybody has what they need, which is hospital coverage. Well, today, that's not the way it is. More than half of Medicare's dollars are spent outpatient. So no other health plan does this to you where you have an inpatient section and then an outpatient section. Just Medicare does this. And there's a fee, a premium every month to participate in Medicare Part B. It is $148.50 this year. We don't know what the premium is exactly next year. I'm betting it'll be $160. And the reason I'm thinking it's going up is because they're going to probably give you a 6% increase on your Social Security checks. If they don't raise your Social Security check, they can't increase your Medicare premium, but they will. This year, they're going to increase your Social Security check and your Medicare premium will go up. So the government knew that this was a problem. This was 1960s, totally different than the year 2000. So in the year 2000, the government said, we've got to finally address this and modernize Medicare. We've been dragging our feet while every other health system has been modernizing in the 1980s and 1990s. Medicare had not been. So finally in 2000, they got together with the congressional committees, did the studies, and finally passed it so that in 2005, 5 years later, they had a modernization effort started for modernizing Medicare. But they were very, very, very sensitive to the fact that they had 30 million people already in the plan. And the last thing you want to do is tick off 30 million senior voters. So they said they were scared to death of them. And they said, we're just going to leave original Medicare alone. We're not going to force people to change. We're going to make everything optional. If people want to try out new plans, they can, but we're not going to force them to. And we're going to do this over 20 years from 2005 until 2025 so that it gives it a nice, gentle time to turn this battleship around. Well, if you compare that to the Affordable Care Act, where everything was done in about a 3 or 4 year period of time, it really caused a lot of headaches and a lot of problems, and it still is today. It's just now sort of getting stabilized. but it really had some rough beginnings. Medicare did it right. And it's an example of one side of the government doing things right and their sister agency getting things not so well. So be aware, Medicare is doing a good job and it's not been anything major that's been disruptive. But I still got to stay in the 1970s at this point, because before Medicare modernized in 2000, the insurance companies were watching very carefully around the United States. And the insurance companies said, wow, these people are complaining that there are holes in Medicare. So we're going to create a bunch of little insurance policies, which insurance companies love to do that. They'll sell you insurance on your dogs, on your cats, on your refrigerator, on your tires. They love selling little insurance policies to everybody. Well, these little supplements were crazy. There was 1 million of them all around the United States. And the government said, this is nuts. We need to standardize these. And so in the 1980s, they said, we're going to standardize them. Okay. And once they decided to standardize them, they made a mistake. The government sometimes makes mistakes. They had already started calling inpatient Medicare A and outpatient B. And when the bureaucrats said, we're going to have the standardized Medicare policies, we're going to call them with letters A, B, C, D, E, F, G. Well, that was dumb. They should have used numbers or Roman numerals or something else. So now you get confusing. People say, well, I've got my Medicare card and now I've got my secondary insurance card. It's a plan B or a plan G or F. And that's your second card. And now we have a third card because in 2005, the drug plans came out. So this is called a 3-card system. You've got your Medicare card, which is your active, what talks to your doctors and talks to your hospital. Then your Medigap card doesn't talk to anybody. It lays silently in the background waiting for Medicare to instruct it to pay the rest of your hospital bill and your doctor bill. And then the drug plan is separate, that you'll show your drug card to your pharmacist. That's how things get designed over 50 years. In 2005, finally, when Medicare said, we're going to modernize, we're going to kick off the new sides of Medicare, it is a 1-card system. Just like at work, when you have your health plan at your job, you have 1 card. You have your health card, you show to your doctor, to your pharmacist, to your emergency room. That's your health ID card. Well, that's what these are. These are actually designed to be somewhat similar to what you had at work, with a huge difference. There are no deductibles, no outpatient medical or inpatient medical deductibles. But your Part A, which is your hospital, is built right in. Your Part B, you still have to pay your premium, $148.50 this year, probably $160 next year. And almost always a drug plan is built right into this 1 card. And if you've heard Joe Namath, Broadway Joe Namath on TV, or JJ Dynamite Jimmy Walker on TV every 5 minutes, they say, get your extra Medicare coverage. This is what they're talking about. Because the extra benefits in Medicare currently are on these new plans. Under the new $3.6 trillion or $5 trillion tax bill that they're talking about passing, they're talking about adding extra coverage to all of Medicare. Well, that hasn't happened yet, and it may not, but it probably will. But right now, when they're talking about extra coverage in Medicare, they're talking about this new side of Medicare that's been around for about 16 years, called the Medicare Advantage system. But more importantly, if you look here on the bottom left of the screen, this is where Medicare is using networks of doctors. HMO means mandatory network, health maintenance organization, mandatory. PPO means optional, preferred provider organization. It means optional network. So fortunately here in Georgia, most of our companies are offering the PPO options, which are very flexible. There still are quite a few HMO options, which are very strict. But the PPO options are nice because they do allow you to go see doctors nationwide, go in or out of network. It gives you the freedom to choose your own doctor. So there's lots of ways to access this system, but these are your 2 primary ways. When you see on TV, they're generally talking about HMOs or PPOs. But let's talk about, how do you figure this out for yourself? People say, Keith, I'm already lost a little bit. Just tell me what most people do. You know, I just kind of want to do what the crowd is doing. Well, Medicare has noted that it is now 50-50. For people between age 65 and 70, 50% are accessing Medicare through a traditional way, and 50% are accessing Medicare through the new PPO or HMO Advantage system. And we've seen that in my office for about 9 years now. We've been tracking this, and it's a fairly, simple 50-50 balance. It doesn't vary year by year. But if you looked at the entire state of Georgia, it's 60-40. 60% of seniors are using traditional Medicare and 40% are using the new plans. But that's when you're talking about people that are even 100, 105 years old. When you're talking about people just going into Medicare right now, it's 50-50. Now, let's make it easy. Really pay attention to this screen. This will decode the mystery for you. And if you like Clark Howard the way I do, I used to take care of Clark's mom, Joy, very nice lady. This is important. Do not overthink this. There are 3 things you need to look at, and I'll make it even simpler in just a second. The first column right here, with a stethoscope in it, is what doctor can I see? The second column with the $sign is, what is this going to cost me each month out of my budget to buy this insurance? And the third column is, what the heck is it going to cost me when I get sick to get better? So who can I see? What's my budget? And what's it going to cost me to get better? So let's use me as an example, okay? I'm not 65. I've got an Affordable Care Act, really, really strict HMO plan, very expensive too. So let's use me as an example. I broke my ankle in February. I slipped on some ice. And on my really strict Affordable Care Act plan with a very small network, I have a $7,000 deductible. I had to pay $7,000 to fix my ankle. I would have much rather taken a cruise around the world, believe me. If I would have had the first item up here, supplement, I wouldn't have had a strict plan. I would have had the ability to see any doctor who takes Medicare nationwide. And instead of spending $700 a month for coverage, I would have maybe spent $200 a month. And I would have bought a drug plan for another $20 or so per month. That's a good deal. And then my ankle would not have cost me $7,000. My ankle would have been free. Or maybe I would have spent $200 to get my ankle fixed. This is fantastic coverage compared to what I have, for sure. I'm jealous. But let's look, if you had an Advantage plan, a Medicare Advantage plan, I would have used a PPO Medicare Advantage plan, chosen my own doctor or gone off the list if I wanted to, anywhere in the United States. I probably would have paid $0 per month. That's crazy. 0 per month. People say, how in the world can you have good coverage, Keith, if it's $0? 90% of all of these plans under the Advantage system are a 0 premium. So this is important. The government is paying the plans to take care of you at about $1,000 per month per person. So about $12,000 a year. They don't need to charge anything extra. They're getting plenty of money to take care of you. And then my broken ankle would have cost me about $400 for my little 30-minute outpatient surgery to fix my broken ankle. Either one of these options is light years better than the Affordable Care Act plan I have for my ankle, okay? But let's make it even simpler, okay? On the left-hand side, it says prepay or pay as you go. Your grandmother, your mother, your Uncle Bob, everybody taught you there you can either pay now or pay later. There's no such thing as free. If you want to send off money to an insurance company every month and prepay for your medical bills, that's fine. The ankle wasn't free. It was a good deal, but you had to spend, $150 or $200 a month and send it off to the insurance company, and they're required to pick up your bills. If you do the Advantage plan, you don't send money off generally to any insurance company. But when you do get sick, you're going to have to pay a copay. You're going to have to pay $300 to stay in the hospital overnight. You're going to have to pay $90 to go to an emergency room. You're going to pay $5 or $10 to see a regular doctor, or $30 or $50 to see a specialist. Your MRIs are going to cost you $200. You're going to pay copays, not deductibles. So even though that ankle that I paid $400, or I had paid $7,000 for, if I was on an Advantage plan, I would have paid $400. The real bill on that ankle surgery was probably $10,000. But only paying $400 copay is not so bad. So let's talk about even more things for you to think about. And if you have questions, you can put them in the chat box. And Raquel, I need to make sure you're monitoring the chat box. Before anybody gets excited about any plan, you need to look at the quality ratings. Medicare calls these star ratings. Just means quality. 1 to 2 star means bad quality. 3 to 4 stars is average or above average. And 5 star, which is a rare event, is excellent. The overall star rating gives the companies bonuses. They get more money for each time they get a half a star better than the average. They get extra bonuses, but also they get extra privileges. If a plan is a 5-star plan, which have only happened 5 times in the last 16 years in Georgia, 5-star plan is allowed to enroll people not just during the upcoming Medicare season, but all year long. They get open access enrollment all year long. Pretty neat. It's a good bonus. So now we're halfway through approximately, and the biggest question that we get these days is the cost of prescription drugs for seniors. The last president and the president before him talked about fixing drug prices and helping seniors, and they both did. The current president is working on new projects to try to help seniors with their drug prices. Eli Lilly, one of the drug manufacturers, announced today that they're dropping the cost of insulin, the list prices and the cost for insulin. Insulin should be cheap, and it's coming down finally. Took a lot of pressure, took a lot of activism, but the prescription drug prices are coming down. So this is important, especially if you're an insulin-dependent diabetic. But every single senior needs to understand how to do a drug review. And also every single senior needs to understand that the donut hole, which was a time period inside your Medicare drug plan where you had no coverage, has been almost fully repaired. It was a major problem. This year, you'll only pay 25% of the cost of your drugs during the donut hole versus paying 100% a few years ago. So it's not nearly the boogeyman it used to be. If you have questions about the donut hole, put them in the chat box and we will address them. But look at this. There's going to be a 100-question test at the end of this presentation. No, I'm kidding. There's not going to be a test. But who would like to learn this in detail? Wow. All these different complicated features of the Medicare drug plan. A plan could have a deductible this year of $445. Next year, it's going to be $480. Wow, that's getting high. I remember when it was $200. Initial coverage. This is an initial bucket of money every senior gets that has a drug plan. This year is $4,130. Then this boogeyman called the donut hole. Well, we probably should put something in parentheses here that says 25% because you don't really have a hole anymore. It's a partial hole. You pay 25% of the cost of your drugs. And then the out-of-pocket cost is $65.50. This is all confusing. No other drug plan works this way. And at the final level here, if you do get to the worst case scenario, they have a catastrophic level which kicks in where you just pay 5% of the cost of your drugs. The government pays 95%. Let's make it simple. Okay. The simplest way, the government has really improved the Medicare website, medicare.gov. You can go there. There's a video on my YouTube channel that explains exactly how you can set up your medicare.gov account, but do it. Create yourself a password and login, and all of your drugs that you're filling are being reported into that login. So when you go in and say, I want to look at 2022 Medicare plans, and you just have to check off the drugs you're taking. You don't even have to type them in. They're there. And then you put in your pharmacy. You can also put in a couple different extra pharmacies if you want to compare Kroger to Publix to CVS, that's fine. And then you hit go. And it doesn't say, I'm going to show you 28 different drug plans and you're going to be bored for the next 12 hours. No, it'll say, here's your current plan and your drugs next year are going to be $1,200. And then it'll say, here's the plan you should be on. Same pharmacy, same bucket of drugs, and your drugs next year will be $600 without doing much of anything. You don't have to change your pharmacist. You don't have to change your prescriptions. You just change your drug plan. The average error per senior is $720. $720 is a lot of money. Husband and wife, that's $1,500. That's, you can definitely take a vacation on that kind of money, or fix the roof, or fix your car, or whatever. It's crazy what seniors waste on their drug plans, and they don't even know it. Well, this is a big year for this. You need to really pay attention to this. One of the most popular drug plans from last year was about $12 per month. It is going to $93 a month next year. Another plan that was $15 a month is going to $83 per month. If you do not reshop your drug plan, you're going to flush $1,000 away just on the premium. It's ridiculous that the government is allowing plans to go up from $12 to $93. That should not be allowed. They should just withdraw that plan off the market, because what happens is, and the companies know this, so many seniors just have their drug plans deducted from their Social Security check, and they don't do these drug reviews. And you're like, wow, my Social Security check went down $80 a month. That's theft. You don't need to let them do this. You need to make sure your neighbors, if your neighbors have dementia or have other problems, they need to get help, because this is free money just being deducted from Social Security checks like crazy. So do your drug review. And it's not hard. We do it for free for our clients, but you can do it on the Medicare website by creating your login and your password, and you can do it in there. It's not hard. Call my office, or you can also call a state agency called Georgia Cares if you want to deal with government volunteers. If you're low income, you get extra help. The program's name is actually called Extra Help. And that's where the government will step in and pay for your drug plan for you. If you've never had a drug plan and you say, wow, I'm going to have a drug plan, but oh no, they're going to penalize me because I've never had drug coverage before. If you're low income, they're not going to penalize you. They're going to remove any penalties. So don't worry about that. Get your drug coverage. If you qualify, they'll also not only pay for your drug plan, but they'll also, for some people, will pay to reduce the cost of their drugs. If their blood thinner is normally $100 a month, they'll buy it for $9 a month. If they have a generic drug that's normally $28 a month, they'll pay $3.70 for it. Really good stuff. And they'll also remove the donut hole, the deductible, all of the ugly features under the Medicare drug program, and basically give everybody catastrophic level coverage. 20% of seniors who deserve this extra help have either failed to apply and ask for the help or reapply. They might have been turned down 4 or 5 years ago. They don't realize they can reapply. Okay. Let's see. I want to monitor the chat box a little bit here. I see that we've had a lot of messages in there. All right, in our chat box, you can see how to create a Medicare.gov account. And some of these questions I'm going to keep till the end. But let me address this one that was just here about drugs. Barb asked the question, says, why am I having to pay for a drug plan if I'm not on any drugs? That is a great question, Barbara, and you're not required to pay for a drug plan if you're not taking any drugs. Nobody is forcing you to buy a drug plan. That's the way it is in the United States. Drug plans are optional. You're not required to. However, why should you have a drug plan? The cheapest drug plan in Georgia this year was $7.30 per month. And if you're not taking any drugs, like my mother, you don't know that if tomorrow you might get tetanus, or you might have a car accident, or you might get COVID, or you might get hepatitis. You don't know what's going to happen tomorrow. So by having a drug plan in your back pocket for $7 a month is a wise financial decision, because then you will have coverage. Because if you don't buy a drug plan, you'll have to wait until the next open enrollment period, which is here in October, and they'll award you a drug plan for January 1st, unless you're low income. If you're low income and you apply for this extra help benefit and the government awards you the extra help, then they'll give you a drug plan right away. But it is very, very smart to have a drug plan in your back pocket. If you're a veteran and you get your drugs from the VA, that's fine. That is your drug plan. So veterans are not penalized for not having a drug plan. But yes, that's a good question, Barb. Make sure there's not any others. There's another question from John. John asked the question, what is the income level for single and couples to be considered low income? You can call my office on that, John, but it's generally around the federal poverty limit, around $13,000 for an individual and around $15,000 or $16,000 for a husband and wife. So you can, we've got that information. You can call my office, or you can also call Department of Health and Human Services in Georgia. So next question on the chat box is there still a penalty for not enrolling in a drug plan when you're Medicare eligible? Yes, there is a penalty. So what happens is, and we're going to go over some of these penalties in a minute, but what happens is they will assess the penalty in the future when you do finally sign up for a drug plan. So the penalty is calculated this way. The national average is about $33 per month for a drug plan. It's much less here in Georgia, but the penalty is about 33 cents per month. So if you waited an entire year and didn't buy a drug plan, you're going to pay about $4 per year. I'm sorry, $4 per month for every year that you live. Keep on living. So it's a lifetime penalty, be about $48 a year. So about $4 a month. That'll be your penalty for waiting to sign up later. Unless you're low income, then they waive that penalty. All right, now we'll go to the next screen. Sometimes after you do all of this, you still have high cost medications. And you know, it doesn't matter what drug plan you're on. If you've got a drug that's, you know, $1,000 a month or more, I see some drugs that are $10,000 a month, you need help. And so high cost medications generally have what are called patient assistance programs, PAP. Those programs, you would ask your doctor or call the foundations or associations similar to your disease. If you have kidney failure, call the Kidney Fund. If you have cancer, call the cancer foundations, American Cancer Society or other ones to find out about patient assistance programs. There's also a lot of discount drug cards out there. RX Saver cards. If you go to Howard's website, clark.com, I believe he's got a section on discount drug cards. That's fine. Medicare says it's okay. You can use a discount drug card or your Medicare card. You just can't use them on the same drug at the same moment. So you can't combine them together. But if you find out a discount card or Walmart has your drug cheaper than your drug plan, that's fine. Just pay cash for it. It just doesn't get counted towards your out-of-pocket maximum, but it's fine. It's okay to do that. Now we have two questions in the chat box. The first question is, how do you check that the pharmacy you have been using will still be in network this year? I haven't been able to find it on the website. It will show you starting tomorrow on the Medicare website. On the Medicare website, you can put in your pharmacy and it'll show you on your plan if your pharmacy is in network. And you can also click through to the website for your plan and do even more research. But it is starting tomorrow. You'll be able to see what pharmacies are preferred pharmacies for your plan next year. Another question from Virginia is, Eliquis is so high. Is there any comment? Yes, Eliquis is coming down in price. It is a blood thinner. We have some plans where Eliquis, I believe next year is going to be around $35 per month. Some plans this year, Eliquis is $100 per month. So we are seeing that drug come down in price. And then we have a comment from Marion that says, if you are on Medicare, the discount cards aren't accepted. And that's not correct, Marion. So it is allowed. Your pharmacy may be telling you some incorrect information, and I hear this quite a bit. You're allowed to either use your discount card on a drug or you use your Medicare. And if the pharmacy is telling you can't do it, it may be because they've already run through the drug on your Medicare plan. So it is completely false when somebody says, oh, you can't use those discount cards if you're on Medicare. Okay. I teach thousands of clients. I know thousands of people that use, every month are using the discount cards instead of their Medicare plan. It is okay. The pharmacy tech may be incorrect there. All right. And we're going to move on to the next screen. Modern innovations. Watch our time here. I'm not sure who would think that preventive care, annual checkups, is modern innovation. I've had it for every health plan I've ever had in my life. I've had annual checkups. At least that's what my mom told me. But seniors did not. Seniors on Medicare did not get preventive care until initially in 2005. They tested it first in the Advantage and HMO and PPO plans. They tested it and studied it for 5 years. And in 2010, they announced, hey, we're going to start giving everybody in Medicare 27 different preventive care items: pap smears, annual exams, colonoscopies, prostate exams, et cetera. Men and women get different items, of course. It's not perfect. Your doctor might want to do a few more things than what Medicare covers, and you might pay a little bit for some extra stuff. But in general, 99% of your preventive care is going to be covered. That is great. But I still have doctors that say to me, oh, Medicare doesn't cover preventive care. So even though it's been for 11 years now, we still have problems with doctors and offices not knowing that Medicare has been modernized. Gym memberships, item number 2, gym memberships. Well, Medicare does not pay for you to go to the gym, but Medicare allows your plan to offer you free gym memberships. So a lot of Medigap insurance plans are providing some type of gym or fitness benefit, and a huge number of the Advantage HMOs and PPOs offer gym memberships. That's where you can get to go to LA Fitness or Ladies Workout Express and just flash your little silver and fit or silver sneakers card, and you just walk right in. It's awesome. It's really neat because the tracking is that people that use the gym, their healthcare expenses go down by 30%. So it's a no-brainer. It's a no-brainer to use the gym, and also for the plans to give you gym memberships. But there's another item, 3 items there: dental, vision, and hearing aids. This is what, under the new $5 trillion tax bill that they're talking about adding into Medicare dental, vision, and hearing aids, because regular Medicare doesn't cover that. But Medicare has allowed the new plans, the HMOs and PPOs, to do a huge amount of adding dental, $1,000 or $2,000 or $3,000 a year of dental coverage for free, $100 to $300 a year of eyewear and free eye exams, $500 to $3,000 a year worth of hearing aids. It all depends on the plan you're on, and there's no guarantee that your plan offers those extra benefits next year. It is a year-by-year decision for the plans, and they can say, hey, we're going to offer dental this year, and we're going to offer vision and hearing aids. A huge amount of expansion there, and it's brilliant. Most glaucoma is found in a routine eye exam. Periodontic disease leads to brain problems and gastrointestinal problems. Hearing loss leads to brain shrinkage. These are all brilliant things to add on, and that's why regular Medicare is considering, and Congress is considering, adding these on to regular Medicare, maybe by 2025. We'll see. Item number 3, expansion of at-home services. Medicare doesn't cover you at home too much. And so we've seen some plans, very few number, but a few plans are experimenting with giving people services at home. Maybe even Uber or taxi coupons to go get their vaccines or go to their doctor, adult daycare services. But a big one that they're doing is 2 things. A lot of the plans are providing food, either food cooked and delivered to your home. If you've been in the hospital, we're going to bring you meals. That's smart. Or an actual grocery card where you can get $50 to $100 a month of free groceries. They're not going to buy you Cokes and Oreo cookies. They're going to buy you fruits and vegetables and grains and rice and staples. That's pretty smart to help seniors out with their food purchases. But a really neat section is that a lot of the plans now are providing OTC, over-the-counter medical items. And this is stuff that Medicare has never covered. Medicare doesn't cover Band-Aids and sunscreen and vitamins and cough syrup and allergy medicines. But a lot of the new plans will give you a catalog. You can either go to Walmart or a store, but you get a catalog or go online and you say, I want to have cough syrup and vitamins and sunscreen delivered to me, and they just deliver it to your house. It's brilliant. It's the same stuff you've been buying, putting in your medicine cabinet. They'll just deliver it to your home. I think that's smart. Those are medical care items. Now, number 4 is what's going to save Medicare. You know, Medicare is doing great, except there's 5% of people, 5 people out of every 100 people spend half of Medicare's dollars. So think about that. 5% is spending 50% of the money. So Medicare has been tracking this now. Finally, they should have been doing this 25 years ago. Tracking it now and saying, okay, let's get extra help to the diabetics, the heart and lung patients, the kidney patients, and low income people. Low income generally translates to low health outcome. Low income, low health outcome. So let's get them extra benefits and help them to become healthier, have better care, better practices, better prevention, et cetera. And another thing that Medicare is also experimenting with that's going to become permanent, the hospitals have pioneered this, is care coordination. You leave the hospital, let's make sure you don't show up in the hospital a week later. Let's make sure you're getting care, you're going to your follow-up visits, you're getting your oxygen delivered. Let's make sure that you're getting better, because Medicare penalizes the hospitals when you show up back on their doorstep within a month. So they're really working on care coordination, very smart things to do. Got a few more minutes here. We're going to spend about another 10 or 15 minutes. And the big question for people is, wow, how do I get into Medicare? And then how do I manage Medicare? Well, it's pretty easy to get into Medicare. When you turn 65, if you're not working, you don't have other coverage, you just use your initial election, which is your birthday month. Your Medicare will start on the first day that you turn the month that you turn 65. You can do that 3 months ahead of time. And if you forget to do it, they give you up to 3 months afterwards to do it. So they'll give you a total of 7 months. But not everybody needs to sign up for Medicare when they're 65. We have a huge number of people who are working longer. They're on their spouse's benefits, or they're working until they're 70. Huge numbers. And so those people would use what is called a special election, because if you're retiring from work and you're 69 years old, that's a special circumstance. If you're moving from Georgia to Florida, that's a special circumstance. So these special election moments or periods, those special election periods are huge. There's a huge number of them. And this is where my office really shines, because the consumers and Medicare itself gets confused by these. For example, last year we had a COVID special election for COVID, a huge extra relaxation of the rules. We had special elections due to people affected by hurricanes and winter storms. And then we had a special exception election period for people who had been affected by peaceful protests. So we've got all these different rules that are floating around, and we know how to decode these for you. So I get people calling me in June or July, like, I've got a problem with my Medicare. How do I manage this? We look for the solution, and then we fix it. That's what we do. If we can't fix it with a special rule, then everybody in Medicare gets the annual election period. This is where you're able to change your Medicare plan beginning October 15th. Now, I told you earlier that tomorrow is October 1st and Medicare turns on, and we can see the 2022 plan starting tomorrow. Well, that's a preview. October 1st, October 14th is a preview, whereas October 15th to December 7th is actually the enrollment period. And the reason they stop it on December 7th is so the companies can print your ID cards, mail you your welcome packets to you, deal with Christmas and New Year's, and deal with the exceptionally slow US Postal Service. And so everybody can have their ID cards by January 1st. That's the goal. If you're fail to do the annual election and you're in a Medicare Advantage plan, the last president created this period, which was wonderful, because people would forget. They'd go to see their doctor or something in January or February and find out their doctor's not on their plan, or they would go in and find out a drug wasn't covered, or they'd find out that their brother Bob has got a much better dental and vision hearing aid plan than they do. And they're like, we need to fix our plans. Well, now we can. In January, February, and March of each year, it is a one-time mulligan, a do-over, where you can fix your plan. And we do a huge amount of help of seniors during that time period, fixing mistakes that they didn't fix during the annual period. Some people just turn off the hearing during the annual period, say, I'm sick of hearing about Medicare, and they don't do what they're supposed to do. Well, at least now we have a relief valve in January, February, and March. Now, remember, special needs people that are low income or that have chronic illnesses, heart, lung, kidney, and diabetes, they get special needs plans where they can fix their plans generally one time per quarter every 3 months. So let's talk about these penalties. We had a question earlier about that. And I'm going to answer some questions in a second that's in the chat box. I'll get to those questions in just a second. Let's talk about financial penalties first, though, because if you don't do things right, they are going to penalize you. COBRA, some people leave work and they say, I'm going to take my work insurance and pay for it called COBRA instead of taking Medicare. No, don't do that. That'll create a lifetime penalty. If you have a spouse that needs the COBRA, the work insurance for a while, put it on the spouse, but the older person needs to go into Medicare. If you don't do this right, you'll have a penalty that's severe under Part B, the outpatient portion, about $15 a month for the rest of your life for every year that you avoided taking Medicare. And the same thing on the drugs, but it's not severe. It's a severe penalty. It's about 33 cents a month, about $4 a year. So it'd be about $48 total per year, $4 a month would be charged to you. If you're low income, you don't pay these penalties. They'll wipe those penalties out for you. So don't worry about that. If you're low income, high income people, they'll get a double penalty. Not only would they get their late enrollment penalties, but they also get an income penalty. If you're $88,000 a year or more for an individual, or $176,000 or more for as a household, a couple, you're going to pay more, sometimes a lot more. If you get up to $700,000 a year in income, you pay a lot more. And that's a 2-year look back on your income. Now, on the chat box, we had a question that I want to answer, and then I'm going to make sure we're not missing any other ones. Raquel, make sure you're watching these things in the chat box. But I'm going to answer this question about what's low income. As most retirees have no employment income, they have retirement income savings. All right. What the government is looking at is your modified adjusted gross income. If you're receiving required minimum distributions from your retirement account and you have to pay taxes on it, that's income. Part of your Social Security income is taxable. That's income, but also the non-taxable portion of your Social Security is also considered in this calculation. So it's all of your Social Security income. If you sell the beach house and have a capital gain on that sale of that second home, you're going to pay taxes, and that's income. So I hope that answers that question. Retirement savings income can still be income. Tom, you were asking that question in the chat box. So let's go back to a couple other questions that I wasn't made aware of here. So let's see. Nancy says, my doctor is not charging me for all of my annual exam, although Medicare is not allowing it. I think this is blood work. Well, that can happen, especially on blood work. On annual exams, preventive care, if you're on an Advantage plan, you'll probably pay $5 or $10 for that blood work to be done. The doctor needs to code that as diagnostic, not as preventive, for your plan to cover it. So if the doctor's coding it as preventive blood work, then that's why it's not getting covered. That's the doctor's fault. What else there? We have another one there. Margie, to everybody, ask a question. I am in the donut hole in Eliquis, and it's costing $131 per month. That sounds right, Margie. Eliquis is about a $500 a month drug, and during the donut hole, you pay 25%. So that sounds like they are charging you the correct amount for your Eliquis. Any suggestions? Yeah, make sure during these next 3 months that you shop a new drug plan to see if you can get your Eliquis down to $50 per month or less. Let's see here. Joy asked a question in the chat box. If I have a supplement, would they also cover hearing aids, glasses, etc., once they are approved by Congress and added to Medicare? Yes, that is what is in the bill that is being negotiated right now. That yes, it doesn't matter that you have a supplement. It matters that you have traditional red, white, and blue Medicare, And if they add the supplements, the dental, vision, and hearing aid coverage, then everybody in Medicare will be assured to have that, no matter what side of Medicare you're on. Okay. And then Linda has a question here. I have heard comments about Medicare Advantage plans being discontinued. No, Linda, that is not correct. That is an embedded portion of Medicare. Medicare projects, the Medicare directors project that half of all people in Medicare will have the Advantage programs in about 3 to 4 years, and half will have traditional Medicare. So no, the Advantage system is not going away at all. And Patrick asked the question, what about out-of-state Medicare Advantage coverage? Fantastic question, Patrick. If you're on a Medicare HMO, you only have out-of-state medical coverage in an emergency. If you're on a Medicare PPO, you have nationwide coverage. Whether it's an emergency or not, you have nationwide coverage. Great question, Patrick. Let's see here. Make sure I'm not missing any other questions. All right, let's go to the next screen, everybody. All right. Now, I know you guys all feel like you're Medicare experts. In just a 30, 40-minute class, you guys are ready to pass the 1,000-question test. No, it's not going to happen that way. I've been doing this for 26 years, and I learn something new every week. But remember this, we're going to recap a couple things here. Medicare does not cover everything. If you want full dental coverage, talk to your dentist, make sure that they participate in plans, and we can get you full dental insurance. And that's permanent. As long as you pay for your dental premiums, you've got permanent dental insurance. Critical events, what that means is heart attacks, strokes, cancers. If you want to buy the duck, a little insurance policy sold to you by the duck for critical care, that's fine. Medicare says that's okay. You're allowed to do that, and it'll help you in times of crisis. Medicare does not pay for burial like life insurance. So if you want to have your burial covered, you need to talk to your financial planner or your life insurance agent about that. But the big one is the last one, home care assistance. Medicare does not cover home care assistance. A little bit of some home therapies and a few minor things, but you got to buy your own insurance called long-term care insurance, or have veterans benefits called aid and attendance benefits to get home care assistance. Or you got to sell your beach house and take that cash to pay for it, cash out of your own pocket. If you want to go live in an assisted living home, those aren't cheap, but you can do that with your own money. Medicare doesn't pay for it. What Medicare does pay for is 20 days, if you qualify, 20 days for free, no matter what kind of Medicare plan you're on, Advantage or traditional Medicare. The first 20 days of rehabilitation, skilled nursing rehabilitation, is covered 100%. After that point, another 80 days can be covered, rarely is, but you can get up to another 80 days covered for a grand total of 100. But after that first 20 are being free, you're going to have to pay a portion of the next 80 if you're on an Advantage plan. If you're on a supplement, most of the supplements will pick up all of that rehabilitation charge. But I have to really qualify this to say, if you qualify, because there are strict rules that happened in 2019 and 2020 that revised how much rehabilitation care is being doled out. It's gotten a lot stricter over the last 2 years. All right. Okay, good question from Forsythia, or Forsythia. I'm not sure how to pronounce your name. Sorry if I butchered it. Forsythia says, is it still true Medicare pays for skilled nursing only if you've been in the hospital for at least 3 nights? Well, this is the best question of the day. Forsythia, this is very, very good. The question is, under traditional Medicare, there's always been a 3 midnight rule that you had to be in the hospital 3 midnights to qualify to go to skilled nursing rehabilitation. They waived that rule starting in about May or June of 2020 because of COVID. They wanted to free up beds. So they didn't want people just sitting in the hospital for 3 days. If they could get them out and get them into another center, get them out so we could free up the beds for COVID patients. But they've been talking about getting rid of that dumb rule for 10 years. We're hoping they're going to get rid of that rule. But the Advantage plans, the HMO and PPO Advantage plans, have never, ever had that rule. So they've been testing it under those plans of not requiring 3 nights in the hospital, but traditional Medicare was studying that first. They just need to get rid of that rule. But another part of that rule that is really fouling people up is that if you go into the hospital and one of those nights is called observation and you're not truly inpatient admission, then that can foul up your qualification for skilled nursing too. So there's a new proposal in Congress to say any sort of observation or admission at the hospital will count towards your 3 days, but they're also just trying to flat get rid of the 3-day rule because it's antiquated. Great question for Cynthia. All right. Man, you guys have the best questions today. Ooh, Betty, I don't know if you have a typo or not. Betty asked the question, what is the difference between Medicare regular and Medicare HBO? I'm going to assume you meant HMO there, Betty. A huge difference. Traditional Medicare allows you to pick your doctor by asking what doctor takes Medicare. If you're on a strict Medicare HMO, Health Maintenance Organization, the new side of Medicare, not a PPO, but an HMO, you have to use the doctors they tell you to use. The plan says these are only the doctors you can use. So that's a huge difference, Betty. And there's lots of other differences, but that's the big difference right there. Another question from Phyllis to everybody. Why does my insurance want to keep coming by my house for a consultation? Well, a couple reasons. They get paid to do that. It's a bonus. They get bonus for doing these home visits, but it's also a program under what is called social determinants of health. And that is going to visit seniors, oftentimes seniors living in isolation, visiting them at their home, just walking up to the home. If the grass is 3 feet tall and the front screen door's fallen off and the dog looks like he hadn't been fed, and then they go inside the house and find out the senior's living as a hoarder or has 12 guns laying around the couch, you know, they look for other signs of mental illness and other things. You're not required to have anybody come to your home. You can meet them somewhere else and do a free health screening. But Medicare is paying all of the companies to go visit you in your home to do these home visits. And they are keeping data on that stuff. It is supposed to help the health system, but if you consider that an invasion of privacy, you're not required to do a home visit, okay? During COVID, it's pretty handy though. All right, I wanna make sure I'm not missing any other questions. Okay, we're going on our screen to the next screen. Recap, we'll get done here in just a second. There are 2 paths to take, either the Advantage new system or the traditional classic supplement systems. Half of people at age 65 are doing the new system and half are doing traditional. That's exactly the way it is at my office with all of our clients. And again, all of our services are free. But notice what it says here. Your decision is not permanent. People think they're making a lifetime decision. No, you can move between these 2 systems. I do it every year with my clients. It's not perfect. And I wish I could move them every single time I try, but most of the time we manage the Medicare pretty well. It's just sometimes the state laws interfere with the federal laws. Medicare does not cover everything. You want to review your plan every year from October 15th to December 7th. Call my office now. The information is in the chat box. Call us and we'll set you up an appointment probably for November at this point. But remember, dual people who have both the Medicare and Medicaid or the chronic illness situations, they get special plans and special privileges all year long. So those people, if you know somebody's suffering, they need to call me. Everything's a process. Give yourself 3 months before turning 65 or retiring. It takes Medicare about a month to get your Medicare ID card taken care of. Gives you some time to do some shopping. Make sure you talk to your doctors and your dentist. And then on your birthday or retirement date, we're ready to go. But remember, anybody that even when they sign up for Medicare this year, they still should probably do their first annual review in October. Okay. This is the name of my company, Affordable Medicare Solutions. We're in Suwanee, Georgia, straight up 85 from your area, before the Mall of Georgia. And but most of the people are meeting with us today through Zoom, or if they want to come in person, we're allowing vaccinated people only into the office. We're all vaccinated. We promote vaccines here. And if you want to do it by phone or by Zoom, a review appointment, no problem. We just have to get Medicare permission slips signed. Medicare requires us to get some information signed before we do your review for you, but we don't charge you. All of our services are free. Our website is amsplans.com. And then our website is in the chat box. I mean, the YouTube channel and other things are there. And there's also some more questions. Joy writes a question. My supplement is no longer available to new members. Is it still available to me? Yes, Joy. If you're on a Medicare Plan F, as in Frank, letter F, you'll be able to keep your Medicare supplement the rest of your life, even though they're not making it available to new members. And you can also buy another Medicare Supplement Plan F. But anybody in here on this call that's on a Medicare Supplement Plan F that can change to a Plan G, as in George, should do that. You'll save about 35% on your premium, and it's worth it. Very good thing to do that. Marion writes a statement. I found after the fact that you must pay the Medicare premium 1 month prior. She found out that you must pay that. So if they bill you for your Medicare, and your Medicare, if you don't have a Social Security check and you're paying for Medicare yourself, and they bill you for January, February, March, you should pay it before January. You want to make sure that you're paid up to cover January, February, March. So some of you in here have delayed taking your Social Security checks, and you have to pay for your Medicare by either writing a check or by going online and doing a payment. So be very careful about that. Make sure I don't have any other questions. Raquel, what do you see? Any other questions I might have missed?
I just received a direct message from Jennifer asking, does original Medicare with a supplement Plan G provide out-of-state coverage?
Medicare Supplement Plan G provides the entire United States and U.S. Territories like Guam and Puerto Rico, full coverage. But also Plan G will provide at least $50,000 of international travel coverage to help you as you travel around the world, where Medicare normally does not cover you. So Plan G and Plan F provide that benefit, but some of the one of the main supplement companies here in Georgia provides $100,000 of international travel coverage. So we have any other questions there that you've seen, Raquel?
You have answered all the questions in the chat.
I'm seeing one from Dave that I don't think I answered. Dave says, if you are on an HMO, can you purchase an insurance to cover non-covered providers that you currently pay out of pocket? Well, Dave, that's kind of a sticky question, because there are a lot of medical providers that are called concierge medical providers, and concierge medical providers have a fee where they might charge you $1,200 or $2,000 a year to be in their medical club. And you can do that on top of your HMO. But as far as buying insurance, like a Medicare supplement, you cannot do that. You cannot buy a Medicare supplement while you're on an HMO or a PPO. You can buy some insurance that helps you to pay off the copays. So on the HMO and PPO plans, for example, if you go to the hospital and you have a $300 per day copay, we have plans that will actually pay that copay for you. So I think your question is a little deeper than what I can answer here, but in general, you cannot put a Medicare supplement with a Medicare Advantage PPO or HMO plan. That's actually illegal. Okay. All right, let's see. And I appreciate the thank yous. So I want to make sure we haven't missed anything else there. A lot of great questions today, and we made our time. We were right at 1 hour. This will also be edited and be provided back to Central DeKalb for sharing. If you had any friends that should have come today, you guys can share that with them. And Raquel should have that done in the next couple of days and sent over by email. We also have our YouTube channel that has all of these videos available for everybody. But remember to call my office. Just call us. All of our services are free, and we'll help you navigate these circumstances. But if you have a retirement plan of your own through TRICARE or your work or something else, be super safe that you do not accidentally cancel any of your retirement benefits. Be very careful. And every year during the open enrollment, people do that inadvertently. So please be careful. Everybody have a great day. Thank you very much for coming.
Thank you so much, Keith. We appreciate it.
All right. Have a great day. Bye-bye.
All right. Thanks. You too. Bye.